All right, so now we're going to talk about labor assessment in each stage. In the latent stage of labor, we want to assess vital signs, fetal heart rate, uterine activity, what contractions are they having, vaginal show, do they have any mucus or bleeding, how the mom is doing with labor. We talk about maternal response. Are they anxious? Are they worried? Are they handling the contractions okay? Are they asking for pain meds? And we want to chart that every 30 to 60 minutes. We do a temp every 4 hours until membranes are ruptured. After membranes are ruptured, it's every 2 hours. Okay. In active labor, we do vital signs, fetal heart rate, uterine activity, vaginal show, maternal response every 15 to 30 minutes. Again, membranes intact, temp every 4 hours, membranes ruptured, temp every 2 hours. And we assess the bladder hourly because at this point, when they get into active labor, they may not be able to identify the sensation of a full bladder because there's so much else going on. A full bladder makes labor more painful and it can impede descent. In the last part of stage 1 labor and transition, we assess vital signs, fetal heart rate, uterine activity, vaginal show every 15 minutes. We assess the bladder frequently. We assess the maternal response every 5 minutes because they're going to go from this to ready to push quickly sometimes. We assess for signs of complete dilation, and that's an urge to push or have a bowel movement, sudden appearance of sweat on the upper lip, vomiting, increased bloody show, shaking extremities, involuntary pushing, and increased restlessness. Okay, so we're assessing for are you almost ready to push? Or are you about ready to deliver? Second stage, we assess vital signs every 5 to 30 minutes. That can depend on facility policy. Every 5 to 15 minutes, we assess fetal heart rate, vaginal show, and the maternal response. We assess every contraction, and we're watching for signs of imminent birth. These are different from signs of complete dilation. If the fetus starts descending rapidly, the perineum is bulging, the labia are parting, they're getting ready to deliver. For a first baby, unless the provider has different preferences, we usually call the provider when the head is visible and doesn't retract. If they've had a baby already, we call the provider when they begin pushing because they usually have to push a lot less. In the third stage, we assess for signs of placental separation. The provider should generally still be there at that time, but we're assessing for signs of placental separation and we're assessing fundus and bleeding. In the fourth stage, we assess vital signs, fundus and lochia. That's where is the uterus, how hard is it, and how much bleeding do they have every 15 minutes for the first hour. Usually this is going to follow a post-op frequent vital signs pattern. We assess temp at the beginning and at 1 hour. We assess for their recovery from analgesia or anesthesia. If they had an epidural, are they able to lift their legs? Are they able to lift their bottom off the bed? We assess perineal laceration or episiotomy in their sutures, and we assess their bladder because it will fill rapidly and increase the risk of hemorrhage. Okay, in the next section, we're going to talk about, that was assessment. In the next section, we'll talk more about specific care.